Society's Clinical Practice Guidelines Revision Task Force for the Care of Transgender Individuals. Say that 3 times fast. He has authored multiple manuscripts on transgender youth. I need more coffee this morning, including a recent state-of-the-art invited review in pediatrics and an invited review in the Approach to the Patient series for the Journal of Clinical Endocrinology and Metabolism. He has had a significant experience conducting multi-centers trials and has served as a site PI for disorders of sex development funded by the NIH, platform for basic and translational research. And in addition, he is the PI, multiple PI format for NIH, the impact of early medical treatment in transgender youth. Dr. Rosenthal has served on multiple committees of ES and PES and is currently the PES president. I should also say here that Dr. Rosenthal shared with us that he is an avid figure skater. So we wish him the best in his next competition. And I think this is really timely. Those of you driving in this morning who listened to NPR heard that the Supreme Court will actually be hearing a case regarding transgender youth in the school in Title IX. So it'll be interesting to see how that plays into all of the conversations we're having. So with that being said, you're on, Dr. Rosenthal.
Thanks very much. Well, first of all, thank you so much for the invitation. I'm very honored to do this. New Mexico has a warm place in my heart. My brother lived in Pecos briefly, and I've been to Santa Fe numerous times and Albuquerque, and it's one of my favorite places. So thank you for the opportunity. Just as a somewhat of a disclaimer, I've never conducted a webinar before, so it's a first for me, and I hope it goes the way you hope it does. When I was practicing with Kevin yesterday, we've been practicing for hours. I want everyone to know that. No, when I was practicing with Kevin yesterday, it appeared that the best way to do this was for Kevin to have control of the slides. So I'm going to be saying next a lot. So I apologize for that in advance. But here we go with the first next. Thanks. So just by way of disclosure, I have, starting about 2 months ago, been a consultant to AbbVie Pharmaceuticals there in Chicago, of course, the home of the Chicago Cubs. And basically they are a manufacturer of Lupron, which you probably are familiar with. It's certainly the drug of choice for children with precocious puberty. It's also used in other clinical conditions such as endometriosis and prostate cancer. Basically, a medication that blocks the pituitary stimulation of the testes and the ovaries. And that medicine, as you'll see in the course of this talk, is one of the key treatments that's available for transgender early pubertal youth, but that's completely off-label. So I've been working with that company to try to encourage them to go for considering FDA labeling, because given that this medicine and all the medications, as I mentioned in the second point, are off-label for gender dysphoric or transgender youth, that makes it very challenging for such individuals to have access to these treatments, because it's very easy for an insurance company to deny these medications, which are very expensive. Certainly the pubertal blockers are, given that they're off-label. So that's why I feel that it's an important thing for me to do. Next slide, please. So you could think of these as questions or objectives for this talk. And it's quite broad and comprehensive. And given the request to have relatively limited slides, I know I was asked to give 15 or 20 slides. I ended up giving you a bit more than that, but also quite a bit less than if I was actually giving a live, rather an in-person lecture. So hopefully we can get through most of this. So first, how common is transgender, and why is it important to provide gender affirmative care? What is the evidence that biology plays a role in gender identity development? How should we manage transgender youth? And what are the barriers to care for transgender youth, one of which I've obviously already mentioned. Okay, next. So it's always fun to start with some definition of terms when you're defining sex, but for the context of this, this presentation, we're using the word sex to define the physical attributes that characterize biological maleness or femaleness. In other words, the genitalia. when a baby is born and you look between the legs, most of the time you can tell, is it male or female genitalia. In contrast, a person's gender identity, and I apologize if this is already familiar to everyone, but gender identity in contrast is not something that you can see. This is a person's fundamental inner sense of who they are as male or female. And as with many things in life and in nature, gender identity is not always binary. And it's just important to keep that in mind. Okay, next slide. So this is a cartoon that was shared to me by one of my dear friends and colleagues, and I think it really makes the point of the distinction between the terms. So you see one adult approaching another adult that's pushing a baby carriage, and the first adult is asking, is it a boy or a girl? And the other responds, well, I don't know because it can't talk yet. So I think it really just challenges us to reframe the way we think about the question of whether someone is a boy or girl or male or female, instead of just thinking about what physical characteristics they have, what is their gender identity? And of course, we can't know what a person's gender identity is until they reach an age where they have their self-awareness to know who they are and their ability to tell us who they are. So next slide, please. Continuing with definitions. So what about transgender? So transgender is defined as either a temporary or a persistent identification with a gender that's different from what is sometimes referred to as the natal or assigned gender. Now, I personally have trouble with that term, like what is somebody's assigned gender? And I think actually my host was just referencing the Supreme Court case and bathroom laws. And a lot of this has to do with, a person has to use the bathroom that matches their assigned gender. Well, based on what I was just saying a second ago, if you can't even know what someone's gender is until they're old enough to tell you what it is, how can somebody possibly assign a gender at birth and have that make any sense? So to me, I think it's more logical to think of this as the assigned sex. And there is typically a gender that is assumed based on the physical sex characteristics that's present at birth. But that's really just an assumed gender. We can't really know what that person's gender is until they're significantly older. Okay, next slide, please. It's important to recognize that gender identity is often confused with the term sexual identity or sexual orientation. And I think that we, I guess as allied health professionals or just people in general that speak, can contribute to that confusion. Because, for example, when you think of one of the words that's sometimes used to describe the transgender population is transsexual. So when you hear something that ends in sexual, it's not surprising that one would think, oh, this has something to do with sexual orientation, like homosexual, heterosexual, bisexual. But in fact, it doesn't. So again, whether we use the term transsexual, which there's an evolution in terms, and that term is being used much less these days. But it's just important to remember that transgender has nothing to do with sexual orientation. And in fact, any person of any gender can have any sexual orientation. Okay, next slide, please. Another important change in terminology occurred in 2013, in the spring of 2013, when the American Psychiatric Association came to the decision to stop using the term gender identity disorder, GID, and instead use the term gender dysphoria in children. And this is really important. Just like what I mentioned before for the definition of transgender, the core definition here is a marked incongruence between, and this is the terminology that's used, between one's experienced or expressed gender and the one that was assigned gender of at least 6 months duration. And again, with that caveat that I think I and some people would have some difficulty with the whole idea of an assigned gender. But nevertheless, you could think of it as the gender of rearing, that there's a difference between who a person comes to terms or to the realization who they are and what was expected based on their gender of rearing. The importance of the change in the terminology here is to underscore the notion that being transgender in and of itself is no longer considered a pathology. But instead, thus the removal of the term disorder, but instead to replace that term with gender dysphoria to highlight that the clinical care, the focus, should be on the distress that a person may experience as a result of being transgender. Okay, next slide. So how common is transgender? There was a study that went, was widely referenced a number of years ago that came out of the Netherlands that was published in 1993. That is not the study that is on this slide. But that particular study that I'm now talking about basically suggested that the prevalence of being transgender, particularly if, let's say, male to female, was about 1 in 12,000. And female to male, maybe about 1 in 30,000. But more recent studies, and the one on this slide is an example of more recent studies, suggest that the prevalence is much more common than what I just mentioned here. In this particular study that you see on the slide now, this was a study that was carried out in Boston, where more than 28,000 adults were surveyed. And basically, it was determined that about 0.5%, or 1 in 200, self-identified as transgender. One of the limits of that earlier study in the Netherlands was that you were only counted as transgender if you sought mental health treatment. Because in the Netherlands, where there is nationalized healthcare, they have these very comprehensive databases. But the limitation there was that if you didn't feel the need to consult a mental health person, then you never would have been included in that particular database. So nobody really knows exactly what the true prevalence is, but it's probably certainly much less common than originally, much more common than originally thought. Okay, next slide, please. We really don't know the prevalence in youth yet. You can imagine that would be very difficult to ascertain that. But I can tell you that in our particular clinical program, where at UCSF, we saw, well, actually, even before that we had a formal program, just as a pediatric endocrinologist, I saw my first transgender adolescent. It'll be 8 years ago in 2 months. We now have well over 425 patients in the program, with about an average of 8 to 10 new referrals each month, which is something that really has exceeded anything that I think I or any of my colleagues in the program ever anticipated. Okay, next slide, please. So why is it important? Well, we talked about what the terms mean, how common it may be, but why do we care about this? This is a study that came out last year that I think really highlights exactly why we care. And this is a study that was published in Journal of Adolescent Health by Sari Reisner and colleagues. And Sari is now at Harvard. And this is really a well-respected study. It's a study basically looking at the prevalence of internalizing disorders such as anxiety, depression, suicidal ideation, and in fact, suicide attempts, comparing a group of adolescents and young adults, 180 of them who were either transgender, or here's a term for you if you're not very exposed to this subject, if you're not transgender, one of the terms for being not transgender is cisgender. And if you remember your basic biochemistry, for those of us that took it, if you have two like atoms that are on the same side of a molecule, that would be called cis, C-I-S. And then if like on opposite sides, it would be trans. And so I guess maybe cisgender, is implying that your physical sex characteristics and your internal gender identity are aligned. But in any event, just so that you're familiar with the terminology, what was shown in the study was that for those transgender individuals who had not yet had access to gender affirmative care, in comparison to the non-transgender controls, there was a 2 to 3-fold increase in depression, anxiety, suicidal ideation, and suicide attempts, as well as self-harm without lethal intent. Okay, next slide, please. Now, in the same way that that's obviously very distressing, I think it's also very important to point out a study that came out of Toronto a few years ago, which looked at the impact of parental support on transgender youth. And there are 2 slides here, one of which basically highlights the positive mental health effects, and then the second one, negative mental health effects. Now, Kevin, no, don't go to the second one yet. Okay. Now, hopefully I'm able to, can you see me moving the arrow here?
No, we won't be able to see that.
Okay, all right, well, that's too bad. Okay, so what I'm what I would like to show on this slide is that the dark blue vertical bars are what you see in parents who are very supportive, and the light blue vertical bars are what you see in youth whose parents were not very supportive. So this is a group of 84 transgender youth whose parents are either very supportive or whose parents are not very supportive, looking at a variety going across the screen there of various positive mental health outcomes, such as, if you can see on the far left, satisfaction with life, and then as you go across, you can see, for example, going over to, you see very good to excellent mental health, high self-esteem, etc. So you can see that there's a much greater likelihood of having these positive mental health outcomes if your parents are very supportive. Now we can go to the second slide. Now, in contrast, you can see negative mental health outcomes such as depressive symptoms. You can see suicidal ideation and actually suicide attempts. And you can see that if you have supportive parents, you have a much lower risk of having one of these negative mental health outcomes. But Kevin, if you can look at the middle bars over here, you can see that even with supportive family, parents in particular, that more than a third of these kids still have considered suicide. So that, I think, really gives us pause and makes us realize that even, in the best of, the best of circumstances, at least with parents, it can still be very, very challenging in the world we live in. Just as an example, that the Supreme Court has to hear a case of someone who simply wants to use the bathroom that matches who they are. And so imagine if you had to live with that, every day and experience what many people refer to as microaggressions every time you have to go to the bathroom, or perhaps every time often when you have various social interactions. Okay, next slide, please. So now we're going to move into the second part of the talk, and the second and third parts of the talk, which are there neurobiologic and or genetic markers for transgender, and then how should such patients be managed? Okay, next slide, please. So the first thing that I want to talk about just a little bit is that I think there are a number of studies that have emerged in recent years that have indicated, I think quite strongly, that gender identity is not just simply what some people refer to as a psychosocial construct, but much more likely reflects a complex interplay of biology as well as environment and culture. So if we could go to the next slide, please. And there are any number of compelling studies that really suggest that biology does play a role in gender identity development. And these insights come from three biomedical disciplines: from genetics, from hormone studies, and from brain studies. And I would want to say at this point that it's important to say that an interest in this kind of work, or participating in studies that are focused on understanding the role that biology plays in gender identity development, is not meant to develop a litmus test of transgender. It's certainly not to pathologize a situation. I mean, I had the opportunity to learn from one of the people in the audience when I gave a talk in greater detail about this aspect now on biology of gender, who came up to me afterwards and was quite upset. This was an openly transgender man, or someone who revealed that he was. And he, like many transgender individuals, had a history of negative experiences interacting with the healthcare system. And when he heard me talking about this, it really raised, the hair on his body, because he felt that, studies like this could just serve to pathologize the situation. And my feeling was that it's important to say that this was not certainly my intent, that I appreciate that while knowledge can be misused, it can also be very empowering. And I think that my goal in talking about this aspect is that hopefully, by showing that biology plays a role in this, and that it's not necessarily it's not something that you choose any more than choosing your sexual orientation, that this can promote increased understanding in the world, and hopefully in turn increased acceptance and quality of life. I mean, it drives me crazy personally when I hear any number of very prominent individuals, often politicians, who really are not informed about any of this, who make statements that like, a man is a man and a woman is a woman, and this is all nonsense. And I just think that maybe maybe having some of this information get into the public discourse could be of benefit in terms of promoting increased understanding and acceptance. Okay, next slide. So if I were giving this as a grand rounds, which is what I typically do, I would be spending about half of the lecture time on this section here, but I've really cut it down to just a few slides. But I'm happy to take some questions at the end about this in particular. But I just wanted to show you just some selected studies that I think really support the concept that biology plays a role in gender identity development. So this is one of those studies, and this looks at a role of genetics. And this is a study that was done in twins, and it came out of Europe a few years ago. And the question that was being asked in the study was, what was the concordance for gender identity? Meaning, if one of the kids in the pair of twins was transgender, what was the likelihood that the other one would also be transgender? So they looked at a group of identical twins. If you can put the cursor up by that 23, you can see that in the study they compared 23 pairs of identical twins with 21 pairs of same-sex but non-identical twins and an additional 7 pairs of opposite, obviously non-identical twins. And what they found, if you look in the results section there, is that when you looked for concordance in the identical twins, there was about 39%, meaning that if one was, there was about a 39% chance that the other one was also transgender. In contrast, if you look at the non-identical twins, whether they were the same sex or opposite sex, there was 0%. So this to me is very compelling data because it's quite significant. 39% is obviously much greater than 0%. Now you might say, well, gee, if the DNA, because identical twins are sharing the same DNA versus non-identical twins are not. If the DNA is important, why is the concordance only 39%? Why isn't it higher? And there are any number of potential explanations for that. One of which is that we know that there are things called epigenetic changes which can modify the DNA. So even if you have the same sequences of DNA, it can affect which genes are turned on and which genes are turned off. And then in addition, we also know that people who are transgender come out at all different ages. And so there are any number of factors that can influence this. And as I mentioned earlier, when you look at the prevalence of transgender in this or any study, there are going to be some inherent limitations to these studies. Number one, what is that person's degree of self-awareness? Number two, what is that person's willingness to disclose that with the person who's asking the questions? But nevertheless, even with those limitations, I think the fact that you have 39% in the identical twins versus 0% in the non-identical twins is very compelling evidence. Now, based on this, any number of laboratories have tried to figure out what is the gene or genes that are responsible for this. But up until this time, there have not been any confirmed observations. Okay, next slide. Now I'm skipping the evidence. Well, no, I don't have a slide of this, but I'm going to tell you a little story that gives an example of the role that hormones play in gender identity development. I don't know how many, if I could be looking at you and seeing a raise of hands, well, I can see people in the room, the main room there. So I'll ask if any of you have read the book, As Nature Made Him, The Boy That Was Raised as a Girl by John Colapinto. Have any of you raised that? Maybe raise your hand if you have.
You do thumbs up or thumbs down.
So, I didn't hear that.
So people can do thumbs up if they've read it.
Okay. All right, I can't really see thumbs, but you got to wave your hand. Okay, doesn't look like anyone's read it. But this is a very interesting and I think very powerful book to read. This is the story of identical boy twins from Winnipeg, who, it's a true story, who had not been circumcised in around the age of 13 months following long histories of problems with the foreskin. The parents decided to have them undergo circumcision. And the person who normally did the circumcision procedures was out of town. And so they had someone who was retired, not that there's anything wrong with retired people, basically come in and try to do the circumcision. And there seemed to be some problem with the cauterizing machine that was being used. And this was done with an electrode to try to burn off the foreskin. And this physician tried to do it, and then it didn't work. And so he kept cranking up the voltage, and then all of a sudden there was this burst and basically he fried off this kid's penis. And of course, this was devastating. And to make this part of the story short, basically the family was completely freaked out, lost, and was given the advice that there was a clinic at Johns Hopkins, in Baltimore, of course, where there was a psychologist there by the name of John Money who believed very strongly that when it came to gender identity, it really was all about nurture. It was the whole time of the nurture versus nature argument. And the whole idea was your gender identity only reflected the way you were raised and had nothing to do with anything else. And so he encouraged the family to have this little 13-month-old boy whose penis had been fried off to simply castrate that boy, remove the testicles, and basically bury any evidence that this kid was ever a girl, create a vagina, and just raise this kid as a girl, and again, just hide any of this kid's past history, and everything was going to be fine. Well, it didn't quite turn out that way. I mean, this kid, from the time this kid could speak, was very clear that that there was something. This kid did not accept the fact that she was a she. And even things like urinating, this kid, and no one told this kid anything about whether people sit down or stand up to pee. This kid, despite not having a penis, would never sit down to pee, and just became so depressed. Was the ultimate tomboy. By the way, not every tomboy is going to be transgender, right? Because there's a difference between behavior and identity. But this person kept insisting that he was a he and not a she. Eventually, after, I believe, a suicide attempt, the father came clean and explained what had been going on. This kid basically, at that point, this kid had actually been taking estrogen because there's no ovaries, no testicles. Was told that she was a girl whose ovaries weren't working, was put on estrogen, and this was just intolerable as this kid's body started to feminize. And so they stopped the estrogen. This kid learned who they really were. This kid insisted on going on testosterone. He masculinized, became quite a handsome man, in fact, in my opinion. Actually got married, adopted children, but ended up committing suicide. Was obviously very challenged in life. And interestingly, the brother committed suicide as well. But this, to me, is very, very compelling evidence that prenatal and exposure to testosterone in the first year of life clearly, and perhaps other mechanisms, had a very profound influence on this person's gender identity, despite every attempt to raise this person as a female. Now, that is not, I don't want you to walk away with this little story and assume that, okay, testosterone determines everything, because when you think about a typical, if there's such a word, transgender person who was born with male anatomy but ends up with female gender identity, there's no evidence for any transgender individual that there ever was any kind of hormone imbalance. So while we know that testosterone certainly can play some role in some circumstances, we know that that is not the whole story. Okay, the last part of the biology is what I'm showing you on this next short series of slides. And this looks at what we know about the brain in transgender versus non-transgender individuals. So it turns out that there is a smell test that you can do where you can, upon smelling certain odorous compounds, this triggers blood flow in certain parts of the brain. And you can actually measure the blood flow in response to smelling these compounds using a technique called PET scanning or a functional MRI. And these two compounds that they had individuals smell, I hope you've got your coffee in front of you, because that probably would smell better than this, but one is like a cocktail of human male sweat, semen, and saliva. I don't know if they have that in New Mexico, but and then the other one would be the urine of pregnant females. And next slide, please. Who knew? Who knew? But it turns out that there is what we call a sexually dimorphic difference in the way people respond to these smelling these compounds. And what I mean by that, sexually dimorphic just simply means that there's typically a different response according to a person's sex. Now, not gender, but sex. So if you have female genitalia versus if you have male genitalia, there's like a different response here. So everybody has a response, but it's typically dependent on what your anatomy is there. And perhaps not surprisingly, when the females smell this kind of man juice, you might call it, their blood flow is activated, whereas that only happens in the males. These are non-transgender individuals. When they smell, who knew that males' blood flow in their brain would be activated by smelling the urine of a pregnant female? But in fact, that's been well described. And so in this particular study, they took 12 transgender male to female adults. So this is what we would refer to as a transgender female. So someone who starts out with, who has male anatomy, but has a female gender identity. And this is someone who is, in the study, these people had not yet been treated with estrogen. Okay, so they didn't want that to be complicating the study. And then they had 24 controls, 12 that were, these were all non-transgender, and some that were male and some that were female. And one of the other things that they made sure to do in this study, because you may be thinking about whether sexual orientation has anything to do with this, these male to female individuals were all attracted to women. Okay, so they had male genital anatomy, and they were attracted to women, but they had a female gender identity. And so that was so that when they were being compared to the 12 male controls, if you can, Kevin, if you can just point to that again, these 12 male controls also obviously had male genital anatomy and were heterosexual, as it turns out, and had male gender identity. So the only difference between them and the 12 male to female adults over here is just simply their gender identity. So they both shared the same genital anatomy. They both were attracted to females, but for the transgender individuals, they had a female gender identity, whereas for the controls, they had a male gender identity. And what they found when they did the smell test on those groups was that in the transgender females, they also had the female pattern even before they were treated with estrogen. Okay, next slide. Now that study was done in adults, and this is a study that followed up on that, and it's the first time this has been done in adolescents with gender dysphoria. And they had 38 of them, about half of whom were female to male, the other male to female. And then they had an almost equal number of controls, and they only used that compound that's in the sweat and semen. And if you go to the next slide, it shows the responses. First of all, this shows that sexually dimorphic response that was present in the adults is also present in the control girls and boys. If you don't see the sex difference in the controls, then it doesn't make sense to do the study. So the first thing they did was show that the control adolescent girls and boys had a very similar pattern to the adult females and males, such that if you look at the bar on the left over here, you can see that when the control girls smell this stuff, there is an increase in blood flow, and then an inhibition, an attenuation in the control boys. Now, if you go to the next slide, when you compare the controls to, now when they say girls with gender dysphoria, that's what we would refer to as a transgender boy, meaning someone who has a female genital anatomy but who identifies as a male. And then in the same way, if you look down at the bottom half of the slide, you see the boys with gender dysphoria. Oops, no, next slide. Yeah, just the bottom half of this slide, okay? So you see the control boys down here. It's the same as what you saw on the previous slide. So the control girls on the top, there's an increase. The control boys on the bottom, there's a decrease. And if you look at the boys with gender dysphoria who identify as girls, you can see over here on the left, yes. It's weird not to have control of the arrow, but you're in the right place. Okay, so the boys with gender dysphoria, meaning they identify as girls, you can see just above it, they have the exact same pattern as the control girls. And then if you shift over to the right, the girls with gender dysphoria who identify as boys, they have exactly the same pattern as the control boys. Okay, so next slide. So basically, I think that even though there's a lot that we don't know about what role biology plays in gender identity development, I think these sorts of studies, the genetic studies, the endocrine studies, and there are many, I only just gave you the story of one, and there are many brain studies now that also are consistent with with brain structures that are more closely aligned with a person's gender identity than with their physical sex characteristics. I think all of that really suggests that biology does play a role in this, and that gender identity, just like sexual orientation, which of course are distinct aspects of being human, are unlikely to be something that someone, I don't think there's any evidence that it's something that you choose. The only thing that you can choose is whether or not you act on it. So this is the last part of the talk now. So what do we know? What are our gaps in knowledge, and what are our priorities for research? Next. Okay, so one of the things to know is that when you look at little children with gender dysphoria, and you follow them up till the time that they begin to go through puberty, in the majority of these kids, the signs, the symptoms of gender dysphoria either diminish or disappear completely. But for those kids in whom gender dysphoria persists into early puberty, follow-up studies have suggested that these kids are very likely to be transgender through their adult life. So next slide. Now, one of the big mysteries, or one of the big questions, is for that younger group. Why? What is it that determines whether somebody persists or does not persist? If they appear to be gender non-conforming as a young child, whether or not they persist in identifying that way when they start to go into puberty and subsequent adulthood. And it's probably that the reason that it's probably not a very high persistence rate is that this is undoubtedly a very heterogeneous, a very mixed group, where there are some kids who are just kind of thrown in there that were never destined to be transgender in the first place. Many of the kids, particularly natal males, who do not end up being transgender, end up being gay. And there are any number of kids who end up neither transgender or gay, but just may not fit a stereotype of how our society would define male or female. But in any event, investigators have been very interested in seeing if there were ways to predict who is likely to be one of those persisters. And we don't really have any clear way of doing that in any individual person, but if you look at this particular study on this slide from 2013, from the Netherlands, they're really the pioneers in this work, they found that looking at those younger kids, the ones that were more likely to persist were the ones that had the greater degree of gender dysphoria, the greater intensity of gender dysphoria in early childhood. They were more likely to have undergone a social transition, meaning that they insisted not only that they were the other gender, but they insisted on dressing that way and having a name change and change in pronouns. And if you listen carefully, and this isn't universal, but if you listen carefully to what they said, the kids that turned out to persist often said that they were the other rather than wished they were the other. Okay, next slide. This is a study that I want to be sure you're aware of. This was published earlier this year, and this is just simply a mental health study that is really baseline study for what will hopefully be a long-term outcome study of mental health in kids who have socially transitioned. So this obviously is very controversial, as you can imagine. There are a lot of people who feel that parents who enable this are causing this outcome in their kids, they're pushing their kids into this. And there are many people who feel that this is not at all the case, that the parents are just simply following the children's lead. And there are many people who feel, particularly our group and others, that it is better in the long term for that child's mental health to affirm them where they are. And if it turns out that they don't persist, at least they haven't had to endure years of being told from a very early age that there was something fundamentally wrong with them. So this is an important study in that, in this context. This is looking at 73 prepubertal children who have socially transitioned, and they came from all over the United States. And you can see that there was a majority of natal males there. You can see there's like 51 natal males and 22 natal females. You can see their ages between 3 and 12 when they were undergoing this mental health evaluation. And then they had controls. There was an equal number of non-transgender age-matched controls, and then an additional significant number of non-community controls who are siblings of these transgender participants. And the study was simply parental surveys regarding the child's anxiety and depression from NIH validated studies. And what they found was that when they looked at these transgender kids who had socially transitioned and compared them to controls, these kids, there was no increase in depression. They had a slight increase in anxiety, but not in the clinically significant range. But I think the most important is what you see at the bottom there, that these kids who had socially transitioned had much, much less anxiety and depression versus non-socially transitioned transgender children in earlier reports, where they intentionally, in this study, used the very same report scales so that they could make these comparisons. Okay, next slide. So now the rest of this talk is just going to be focusing on the care of gender non-conforming kids who have reached puberty and who have had an intensification of the gender dysphoria or whose gender dysphoria has emerged at that time. And what we feel very strongly, this is coming from the Endocrine Society Clinical Practice Guidelines, which were published in 2009. And as you mentioned in the introduction, I had the privilege of being on the rewrite of this, which is going to be published at least electronically by the end of, well, soon, within probably the next 6 months. When it comes to kids, we feel strongly that the determination, I probably shouldn't even have the word diagnosis there because, well, gender dysphoria is a diagnosis, but being transgender would not be a diagnosis. It's more perhaps just a determination because many people believe that that's just simply a normal variant in gender identity. But that gender dysphoria as a diagnosis should be made by a knowledgeable mental health professional, and that it's the role of the medical providers to be sure that patients understand the potential hormonal treatments that are available to them. And the hallmark of this is that for a early pubertal transgender youth, using a pubertal blocker can really be life-saving. Basically, this is using the very same hormones that we have used for kids with precocious puberty in someone who is reaching puberty at a normal time but is transgender. Because people have recognized that if you are transgender and you go through the wrong puberty, that can obviously be very, very distressing. And if you can put somebody's puberty on pause with a medication like this, and by the way, these medications are completely reversible, you can give that person more time to figure out who they are, working with an appropriate team, including a gender specialist, and then by not only giving them more time, it prevents them from having to go through the irreversible physical effects of the wrong puberty. It prevents the need to have to go through all these surgical procedures if you've completed the wrong puberty. And the initial guidelines from 2009 say that you could offer that intervention when these kids have reached early puberty, and then you could transition them with cross-sex hormones at about the age of 16 and defer any surgeries such as genital surgeries, if they in fact choose that, until they're at least at the age of legal decision-making. If you go to the next to the last point here, no, up one, back slide, just this line here, this one, yes. There are many programs, including ours, that initiate cross-sex hormones at an earlier age, and I'm happy to talk about that in the Q&A if there's time. Okay, next slide. Okay, so there's really only one long-term study now that's been published, which follows this Dutch protocol, which basically says pubertal blockers at early puberty, 10 or 2. In fact, it turns out that their kids in that study were quite a bit older by the time they started. Starting cross-sex hormones at about 16, and then if they do undergo gender reassignment surgery, that would be at around 20, 21 years of age. And in this study, they looked exclusively at mental health outcomes, and what they found, comparing how they were before any of these interventions, that is a year before they went on blockers, just before starting cross-sex hormones, and then a year after they completed genital surgery, when they looked at their mental health, and if you look under results there, okay, put the cursor there, their gender dysphoria was completely resolved. And something that's very compelling is that when you looked at their overall psychological functioning and their sense of well-being, these measures were the same or in fact superior to young adults in the general population. And none of the patients reported regret in any phase of the protocol. So this is the paper that we typically use when we're arguing with insurance companies, because it's the only paper published so far that looks, now long-term, okay, it's 5 to 6 years, but that's all we have so far. But I think shows in a very compelling way that this 3-step protocol has a significant positive mental health effect. Okay, next slide. We obviously don't have time to get into this in great detail, but there are certainly potential adverse effects when you use these pubertal blockers. One would be on bone mass and growth, the other on brain, the other on fertility. We know, for example, that a bone mineral acquisition happens in a significant way during puberty and young adulthood. And so the question is, well, if you put puberty on hold, are you going to have any kind of permanent deficits in that way? Some people have questioned that there could be some brain effects, adverse effects, so that's never been demonstrated so far. And it is important to counsel all of our patients that when they go on, that is their parents in particular, when they go on pubertal blockers at early puberty, you are not just putting their puberty in general on hold, but you are also therefore arresting their ability to have mature sperm and eggs. And that is important because many transgender individuals, just like people who are not transgender, still want to have the option of having offspring that are genetically related to them. Next slide, please. So what are our gaps in knowledge and priorities for research? If we just look at those younger kids, there really are limited data on predicting persisters, and there really is a need for long-term outcome studies of kids who have undergone early social transition. I think that those studies are going to show that these kids do well, but I think it's important to get that data out there to really inform the very heated discussions. And then when it comes to the early and late pubertal youth, there's no data using blockers in kids younger than 12. For whatever reason, this study in the Netherlands, even though they said they were studying kids at 10 or 2, you saw the average age at initiation of treatment was close to 15 years. And so in our program and several others, we're studying kids according to Tanner's stage and not chronologic age. That is to say that the Dutch not only said, okay, we're going to do early puberty, but we're not going to treat kids less than 12 years of age. And we all know that many people start puberty much, much younger than that. And if you waited until 12, many of those kids are already well along, if not very far along in puberty. There are no published data using cross-sex hormones in transgender individuals less than 16. You can't really do randomized controlled trials for any number of reasons, because, for example, not treating somebody with the pubertal blockers is not really a neutral option, right? Because you're fating them to have to go through what they would perceive as the wrong puberty. So there really is a need for prospective long-term outcome studies of these medical interventions to optimize medical care. Next slide. And I'm just proud and happy to mention, to include in this talk, that our center, along with 3 other centers, have received NIH funding to do a 5-year study. It's the first time that the NIH has funded anything like this in the United States. So it's a multi-center, long-term observational study where we are trying very hard to look at physiologic and mental health outcomes of kids who are going on pubertal blockers at early puberty and people who transition with cross-sex hormones. Okay, next slide, please. Just to finish with a reminder of the barriers to care, as I mentioned at the very beginning, all the medications we use for gender dysphoric youth are off-label. In particular, the pubertal blockers are very expensive and often denied by insurance companies. Limited access to care. I mean, I certainly applaud you for including the subject in your series of talks. There are many programs that have emerged in the country in the last few years, but there still are relatively few clinical programs that offer a multidisciplinary care for gender dysphoric youth. There is no established curriculum yet, even though that's beginning to happen at the levels of medical school, residency, and fellowship. And there's still a lot of prejudice and misunderstanding, including on the part of mental health professionals. So next slide, please. None of the work that we do at UCSF could ever be done with any one person. So we have this wonderful team. We have our program, which is the Child and Adolescent Gender Center. We have 4 directors. We have a director of mental health. You can see on the top, Dr. Diane Ehrensaft. We have a director of education and advocacy. who is Joel Baum. We even have a legal director when needed, who's a sophomore. I serve as the medical director. We have Alana Scherer as the assistant medical director. We have Stanley Vance. I need to update this slide. I apologize. He just became junior faculty. We're delighted to have him with expertise in adolescent and young adult medicine. We have a nurse practitioner, Meredith Russell, and Molly Corin, our social worker. And next slide, please. The Golden Gate Bridge, which I can actually sort of see out my window in the fog. So thank you very much.
So Dr. Rosenthal, we have a number of questions, and I know we're very close to time. So I wanted to group a couple of them together, and I'm going to give them all to you now because it might be that there is an answer that sort of encompasses all of those things. If not, then you can answer them separately. So grab your pen and paper here. So the first two questions to group together have to do with the use of the terminology gender dysphoria versus transgender, and the question of whether or not on that study, the twin study, was there concordance measured on dysphoria, or was it actually measured on people who then were actually transgender at some point? So
yeah, let me try to answer that. So first of all, I think that's a very astute question. Not everybody who is transgender necessarily has gender dysphoria. The study that was done in Europe, that genetic study, to the best of my knowledge, was basically based on gender identity and not specifically gender dysphoria, but I would have to refer you to that initial reference there, which is on the slide.
Okay. And then again, a follow-up to that particular one. So again, looking at individuals who are transgender, are they diagnosed or should they be, or at least screened for gender dysphoria? So what's the relationship between being transgender and having gender dysphoria? So it seems like the audience was a little bit confused about how that all fits together.
Sure. So I mean, these are the words that are out there, and I think many of us sometimes find the terminology confusing. But I mean, again, transgender basically simply is a comment on whether or not there is a divergence or an incongruence or a mismatch between your genital anatomy and your inner sense of who you are, your gender identity. The dysphoria is what a person who is transgender may experience. Not everybody who is transgender feels so motivated that they have to change their body, for example, seek medical interventions. Sometimes people who have severe discomfort that way, that's actually referred, there's another term, body dysphoria. So that can actually, confuse discussions even more. But I think the bottom line is, yes, anyone the people that come and seek services are typically people who have a need for something, right? So if somebody identifies as transgender and they are suffering in part because of the way they are being perceived, the way their body looks, they may feel so motivated because they're suffering to have some kind of intervention.
Okay. And then there are a couple now medical questions here. The first one is functional MRI ever used as sort of a litmus test to prove gender dysphoria in pediatric patients before starting any hormonal therapy, or I would add from what you said in the last few slides, suppression therapy?
So that's an important question, and I apologize if I didn't make this clear. No, absolutely not. So there is, not only is there not, but I don't believe that there ever should be a litmus test to determine whether we can really believe that person is transgender or not. And there are any number of examples. I mean, I have one from my own experience as a pediatric endocrinologist, where we saw not that long ago a couple of infant males. They were like about 6 months of age, that had severe low blood salt levels and seizures. And they had, for all the world, they appeared to have a particular cause of this. And we went to do the actual test to prove what we thought was a diagnosis. It didn't come out. It kept coming out negative. And it turned out they had something that had never been described before. Okay, so, if you have someone who insists that they're transgender, but you come up with some kind of test, it's not at all unusual to think that a person who's truly transgender is not going to meet those criteria. So no, not only is there not, I don't think there ever should be.
Okay.
I think the value, I'm sorry, the value of that research is not to create a litmus test, but just to try to show the world that this is something that is very likely to be intrinsic and not something that someone chooses, and maybe to take this a little bit more seriously. Now, do we have to have a mechanism in order to believe someone? I mean, we don't know what is the mechanism behind anybody's sexual orientation, but slowly the world is a little bit more accepting about accepting someone's sexual orientation. We don't know what causes cancer in most people with cancer, but that doesn't prevent us from having a compassionate approach to patient care. Not that being transgender is a disease, but what I'm saying is, yes, on the one hand, I think particularly for medical professionals, I think a lot of us and our colleagues like to know, well, is there biology and is there a mechanism in order to take something more seriously? But obviously, I do not think that is something that should ever be a requirement in this context.
And I know we're a few minutes over time, but I have one more question for you, if you can kind of hang in there. And you alluded to this a little bit, but is there anything you'd like to add to any long-term health effects of hormone therapy?
Well, the only published studies really so far, there's one published study on bone, basically, but it's very limited, and so there's a great need for a really long-term follow-up. This is really the exciting thing about being involved in this work is not only having an opportunity to work with some pretty courageous kids and families, but also to really try to move the field forward by getting new information. There really is not a lot of long-term data, so we really do need long-term registries and outcomes data to really be able to answer the kind of question that you just asked.
Thanks so much. I really appreciate you taking the time and putting us on your list, given the fact that you have, it seems like, a lot of work to do, and you're on the forefront and cutting edge of this work for the kids and youth in the United States and in the world who are going through this. Is there any parting comment that you want to make before we say goodbye to everybody this morning?
Well, no, I just want to thank you again for the opportunity. I hope, again, I've never done it quite like this before, so I hope it was okay, and I just want to say thank you and wish you luck. And I'm not even sure whether you guys have a program there, but if you do, and if you have any questions or anything that I or our team can help with, please don't hesitate to ask.
Okay, thanks so much. And for those of you who are still on, don't forget to do your follow-up survey. Give us some feedback on how we did today on this particular session of AHI New Mexico, and we will see you guys next Wednesday at 8 o'clock.
Thanks. Bye-bye.